hace tiempo off-label. Yo recuerdo que hace muchos años, en 2013, llevé 10 válvulas de insuficiencia aórtica pura off-label al TCT. No me aceptaron el trabajo. Ahora esto es una realidad. Y it's a real pleasure to have Dr. Makkar and Dr. de Backer. They have been collaborating for a long time, as I understand, with Dr. Lars Sondergaard, with the Savory and the Resolve trial, and many trials about TAVR. And it's a real pleasure to have you here from the very first time, at least, and I understand in Mexico, because the high quality of your skills and also your publications are so important. So it's a pleasure to have you here. Please talk us about aortic regurgitation as a bailout. Please, in TAVR.
Thank you very much. Can I have my slides, please? Terrific. Thank you so much. So I'm going to talk about the use of off-label and dedicated devices for treatment of aortic regurgitation. So I think we are all familiar with TAVR for aortic stenosis, but that has matured quite a bit. And I think there's a lot of excitement now because we have a real need to treat patients with aortic regurgitation, and some of these patients are actually not good surgical candidates. So I just thought I would start with some basic prevalence slides. And if you look at this data from some of the registries, population-based studies, the prevalence of aortic regurgitation is not small. In fact, it reaches almost 2% when you start looking at older patients, all right? So more than 75 years of age and more than 65 years of age, it's almost 1%. So I think this is a lot of people with aortic regurgitation. What we also know is that aortic regurgitation results in adverse outcomes. So it affects survival. And this is actually a lot more pronounced when you're looking at aortic regurgitation and patients have a worse NYHA functional class. So if you look at the survival of patients who are NYHA class 3 or 4 and have significant AR, the outcomes are pretty dismal. What we also know is that if you replace the aortic valve, you can actually improve the outcomes. And the outcomes are more improved if you do the surgery earlier, when the patients are actually NYHA class 1 or 2, or rather than when they are actually class 3 or 4. Now, what is the role of TAVR? If you look at these guidelines, the recent guidelines for TAVR, there are all the class 1 indications there are actually for surgery. There is no real indication for TAVR in the ACC-AHA guidelines. In fact, if you see, it's actually 3, which means harm, and it says that TAVR is rarely feasible and then only in carefully selected patients with severe AR and heart failure who have a prohibitive surgical risk, in whom valvular calcification are appropriate for a transcatheter approach. To some extent, that is true, but I think things are actually changing. This reminds me of what used to be, early on in my career around 2004, such a slide used to be there for PCI of left main. And now it's pretty standard for us to do left main PCIs. So, when you look at the literature, there are no really large series, but there is quite a bit of interest because these patients are out there, and you can in fact see there are a number of different devices, a number of different series that have looked at TAVR for pure native aortic regurgitation. Now, what is the big deal about aortic regurgitation, right? In aortic stenosis, you've got calcium that allows you to anchor to the valve, but in pure aortic regurgitation, the key problem is insufficient anchoring. A lot of these patients actually have large annuli, which may not even be suitable for the largest available device sizes. Insufficient anchoring can lead to dislocation, embolization. Of course, there is risk of residual aortic regurgitation. A lot of these patients have concomitant aortic and LV dilatation. And a lot of times, in order to optimize that, we actually try to overdilate, and which may actually cause annular rupture. Now, when you look at different devices, you essentially look at different devices, and there are different ways in how these devices can actually anchor. So they can anchor in the annulus and aorta. So that's looking at evolute and also looking at the accurate valve, and then looking at annulus only, you're talking about the balloon expandable valves. But I think the most promise may actually come from technologies that actually anchor both in the leaflets, leading to cusp fixation, as well as in the annulus. And here are some of the series. So look at some of these early small series. This is with the self-expanding valve. If you look at the need for second valve, it was almost 20%. A lot of residual more than mild paravalvular leak. The pacemaker rates were high. And then there's small series with the accurate valve. Actually, surprisingly, the results were not bad, in fact. But I think we need more data, looking at this. This is from the TVT registry in the United States. We treat all patients, with TAVR are actually put into a registry. So it allows us to look at every single patient. All right. So in here, what we are seeing is that patients who were treated with self-expanding valves for aortic regurgitation compared to aortic stenosis had higher device migration embolization rates, higher rate of reintervention, and higher conversion rate to surgery. And the mortality rate at 30 days was 15.5%. Now, this is old data. Okay. I think one must qualify that. Now, in 2000, this is data that we generated. My young colleague, Dr. Sunghan Yoon, actually collected patients from 40 different centers. And, these were analyzed at Cedars-Sinai. And what we showed was that in these patients, 331 patients, the mortality was better when you look at the newer generation valves compared to the older generation valves. And if you look at the 30-day mortality, it was still 9.4%. The STS was about 6.5%, so which means that the mortality was actually higher than expected, in terms of what you would expect if you were using TAVR for patients with aortic stenosis. Also, what we saw was that when you leave patients with residual tricuspid aortic regurgitation, your mortality is actually higher. Now, here are some case examples I just want to show you, because you are going to encounter these patients in your practice and you will have no choice but to treat some of these patients. So here's a patient who's 74 years old. You can see there is a very little calcium there on 4D CT. This patient has had a prior mitral valve replacement done surgically. The annulus is large, 616 millimeters square. The vascular access is not bad. And in this case, we actually used a self-expanding valve. You can see it nicely anchors. In fact, the valve in the mitral position, the posts of that valve prevent this valve from actually diving deep down. And we get a very beautiful result, as is actually shown here. All right, so you can actually do this. And this patient had excellent outcomes long-term as well. Here's a patient who's got a very large annulus. There is hardly any calcium. This patient is 84 years old. And if you look at the size, it's actually larger than the balloon expandable valve. All right, which is 29.2. Now, if you use a balloon expandable valve here oversized, you may not anchor, and it may actually fall down into the left ventricle. So we've devised this strategy where we actually used a two-valve strategy. So we use a self-expanding valve, and we know this may also slip down. All right, so we're going to be ready with the second valve. So here is this valve. It has actually slipped down a little bit. There's paravalvular AI. We then go ahead and use a balloon expandable valve inside the self-expanding valve. And you can see actually there is no residual aortic regurgitation. We were able to send this patient home actually on post-procedure day number 1. So we've actually done quite a few patients like this where we've used two-valve strategy with good outcomes. Here's a patient who's 59 years old. This patient had a prior repair done. It's called the David repair. In this case, we were actually able to use a sapien valve because the annulus is not that large. Okay, so we are able to nicely anchor this valve. It's a little bit lower, but there was no conduction system issue. And in fact, you will now be able to do a TAVR in the future because your coronary arteries are actually clear. The other group of patients is patients who have LVAD devices. So here is an example of a patient who has an LVAD. Look at the severe aortic regurgitation. The LV is actually large. Okay, so this patient had a HeartMate device, and this patient was in cardiogenic shock on inotropes despite being on LVAD. And this is the CT scan. You can see the LVAD in the apex. So what we did here was, once again, we knew that we will have to use two-valve strategy. So the first valve was the self-expanding valve. The second valve is actually the balloon expandable valve. And you know what? The valve is low, but it does the job. Okay, so here the LV is very much enlarged, but there is no residual AI, and this patient was actually able to wean off the pressors and actually be discharged home. Here is another patient who had aortic valve surgery, 4 years before this particular procedure, and also had aortic dissection. So I had a TAVR done, also had a David repair done. And if you look at now this patient's valve is leaking. Are you going to do another open heart surgery on this young man? Or are we going to try and fix this percutaneously? And we decided actually that we were going to try and do that, because the anatomy here is something that we thought we could tackle. So the annulus was 582. We thought that we can actually use a 29 millimeter valve and still get adequate oversizing with a little bit of extra volume. So you can see what we are doing here. We are actually coming through this graft. All right. All right, and this is the echocardiogram actually after placing the valve in this particular patient. So the results are actually excellent, and this patient has done well. And I'm showing you echoes now, not just post-procedure at 1 month, and also at 1 year. So you can actually see there is no residual aortic regurgitation in this patient. So, I wanted to make a point here. We published this paper earlier, and when we had 331 patients, when the procedure-related death was 2.4%. But since then, we've continued to do these patients in an off-label fashion with non-dedicated devices, and you can see our outcomes have actually improved. Procedure-related death is down to 1.5%, when the STS was actually 6. If you look at conversion to surgery, it was very low, 1.5%, and aortic regurgitation more than moderate was actually 0%. And the 30-day, survival was almost 94%. So this is not bad, considering that these patients were actually sick and not good surgical candidates. Now, I think the data for research devices is something that I cannot present right now that we have done at Cedars, but I will present to you the data that has been presented earlier using the Jenna valve in the ACC meeting. So I think it is fair to know, as to summarize, that there are a lot of patients with aortic regurgitation, and the outcomes of these patients is not good. The mortality is actually substantial. Almost 10% of patients per year will die. Only 1/4 of patients with aortic regurgitation are offered aortic valve replacement. So there is a lot of untreated patients. And I think the key factor is that we don't have a dedicated device, and hence the excitement about this device. The dedicated device, it's a device that is designed, the Jenna valve or Trilogy heart valve system, it is designed for aortic regurgitation in absence of no calcium. It has these anchors or locators that will trap the leaflets between the valve frame and the locators, so that it actually fixates into the cusps and aligns in the cusp nicely, and at the same time will actually give excellent hemodynamics. So this is the delivery system. It's a long sheath that is actually positioned above the STJ. It's available in 3 different sizes, and we can now actually treat this. This now has a CE mark in Europe, and you can treat annuli that are as large as 94 millimeters. So I think that is a tremendous excitement about this. And here is one such case that I'm showing you. You can see what it is. And we determine by injecting an individual cusp that each of the cusp is there in, each of the locators is there in each of the cusps. Okay, and you can look at the echocardiogram below. There is not a drop of residual aortic regurgitation. So the study that we are doing is actually called the ALIGN-AR trial. It's a multi-center single-arm study, prospective, 180 patients. All patients have been enrolled. Few actually need to be treated, and that should be done in the next week or two. And the all-cause mortality at 1 year is the most important endpoint. And there are also safety endpoints which are actually described here. But the inclusion criteria is typically patients who are symptomatic and who have moderate to severe aortic regurgitation and who are considered to be surgical high-risk patients. These are the exclusion criteria. So we are actually excluding patients with bicuspid aortic stenosis. And these are the results of the first 70 patients that Val Torsten presented at the ACC in 2021. These patients were 74 years old. The STS was almost 4 in these patients. You can see more than half of the patients required large valve size, 27 millimeter. And if you look at the outcomes, the absence of procedural mortality was good, 97.1%. And if you look at other complications, they're also very low. In fact, embolization, one patient, CVA, 1 patient. So these are acceptable results in high-risk patients. And if you look at the all-cause mortality at 30 days, it was 2.9%. Stroke was 2.9%. Other complications are listed there. Permanent pacemaker implantation was 22%. And the pacemaker rate is coming down because we learned how to implant this valve better. If you look at the hemodynamics, they're actually excellent. So look at the rates of paravalvular regurgitation. If you look at, almost 80% of the patients had none or trace, and only 1.6% of the patients had moderate aortic regurgitation, and there was not a single patient with severe aortic regurgitation. So it's effective, it's reasonably safe. And if you look at the hemodynamics, they were actually quite excellent, with gradients in low digits, and valve areas were as high as 2.6 centimeters square. And these are functional data with the JenaValve, once again showing that there was significant improvement in the NYHA functional class. Practically no patients and very few patients in class 3 and no patients in class 4. Almost 90% of the patients were in class 1 or 2. So to conclude, aortic regurgitation prevalence is significant. Outcomes are better in patients who are treated with AVR and treated earlier. Outcomes of TAVR by current commercial self-expanding and balloon expandable technologies were less than ideal in the earlier studies, and they were characterized by high valve embolization, migration, additional valve implantation, and higher 30-day mortality. But these results have improved, and I showed you our results with better case selection and with better learning. And in fact, these results may be acceptable for high surgical risk patients who have no good surgical options. Treatment of pure aortic regurgitation, I think with devices that afford both cusp fixation and annular anchoring may be the best, and JenaValve is a case in point. And the interim results of the dedicated JenaValve system are promising, with excellent reductions in aortic regurgitation, optimal hemodynamics, and low gradients, and low mortality and morbidity at 30 days. Of course, we will need to see the 1-year follow-up, which will be approximately a year from now, when these data will be presented, not this year at TCT, but the following year at TCT. So thank you for your attention.
Thank you very much, Dr. Makkar, for your excellent conference. We are going to have questions at the end of the symposium, if it's okay with you. And after this, I'm really glad and honored to present the next professor. The next professor is Dr. Ole de Backer, who is an excellent and very renowned interventionalist from Europe, actually from the Copenhagen Hospital, University Hospital of Copenhagen. Mm-hmm. And he's going to address to us to this very interesting topic regarding the reduced leaflet motion, the real clinical impact. Welcome, Dr. de Backer, and we are glad to hear you.
Thank you for the introduction. And well, it's nice to have this topic after Raj Makkar, because this is a topic we have been researching a lot together. So it's a pleasure to talk about this. So reduced leaflet motion, the real clinical impact, that was the topic I got and was asked to present something about. And I tried to cover this in the next 15 minutes. And I'll try to do this maybe in a chronological way, so that you can really feel how I would even say historically this whole topic has come to show itself and how it was investigated. So I would say it goes back all the way to 2015, where both Raj and in Los Angeles and we in Copenhagen, we found some kind of a weird aspect on one of these TAVI valves on post-TAVI CT scans. And we saw there a dark zone, and also we had just been implementing some 4D CT, so that means during the whole cardiac cycle, you can see the leaflet motion. And it appeared that one of these leaflets, sometimes in some cases, seemed to be frozen, a frozen leaflet, and we saw that kind of hypoattenuating effect on the leaflet. So we didn't know in the beginning what this exactly was. Was this just an imaging artifact or not? So we started investigating this together, and it finally resulted in this paper in the New England Journal of Medicine. As you can see, Raj Makkar here as first author, and then Lars Sennegård and myself also on the paper here, as it was a common effort from Cedars-Sinai, Copenhagen, and also a center in Germany. But well, we saw this phenomenon in the beginning on some portico valves, but then we started to investigate this also on other TAVI valves and also surgical valves, and actually we found this phenomenon of this hypoattenuating thickening or on CT, this blackness on the leaflets in all different TAVI valves and also on the surgical valves. And what was also even more surprising is that in some particular cases we could see that there was such a frozen leaflet, even one or two frozen leaflets, and that did not impact the transvalvular gradients. So that was why there were some critical voices in the beginning to say this is just an imaging artifact, this is actually not something real you're looking at. But we could see the same on transesophageal echo, so we could see that one of these leaflets was actually not moving, but despite that there was no impact on the gradients. And there was some bench testing done, and it appeared that this was maybe not abnormal to see if this is bench testing setup where one or two leaflets has been closed on purpose. And then you can see actually that indeed if one of the leaflets is just not moving, so this dysfunctional, there is no motion of it, that this does not impact the gradient. It's only in case of two leaflets which are obstructive, and especially in the smaller TAVI sizes, that you start to see some significant and important impact on the transvalvular gradient. Another important aspect was that we saw, because we were thinking, what is this? Is this, because this was seen very early after TAVI, so it could not be degeneration yet. Was this pannus or was this thrombus? So some of these patients were initiated on anticoagulation, oral anticoagulation, and then actually six weeks later, these patients were CT scanned again, and it seemed that in many of these cases, 80 or 90% of these cases, this phenomenon disappeared. So that's why we called it subclinical leaflet thrombosis at that stage, and we got some confirmation that this had to deal with some small film of some thrombus film on the leaflets. So that's why it resulted in this kind of title, so possible, because we were not very sure about it yet, so possible subclinical, because it seemed to be subclinical, it didn't have an immediate impact on the gradient, and leaflet thrombosis, because there were some case examples, both from LA and from Copenhagen, where we showed that this phenomenon disappeared with oral anticoagulation. Later, so then I talk about a year later, we gathered some more information. We CT scanned some more patients. You see, this is already in almost a patient cohort of 1,000 patients, 750 TAVR patients, 150 almost surgical patients. Also some German sites participated here. And it showed that it confirmed that this was seen in all different types of TAVI devices, also in surgical devices, the surgical aortic bioprosthesis, but there was a tendency to see this more often in transcatheter heart valves, aortic valves, than in surgical aortic bioprosthesis. There was also a small tendency maybe to see it, that it was association with an increased rate of TIA, transient ischemic attack. And this is, I don't know, I've referenced it, but the reference falls off, I can see in this layout. But this is a paper also from the group together with Raj Makkar from Chakravarti. And you see this, here there was a small signal that neurological event rates were maybe higher, but at least no significant major ischemic strokes. But more on that later. We also further investigated this is in Copenhagen. We had some of these cases where there was leaflet thrombosis, but we did not change their anticoagulation treatment. So we kept them on their antiplatelet therapy, for example, if they were on the single antiplatelet, and we scanned them a couple of months later again. And then we saw actually that this was a kind of dynamic process. Some halt, some hypoattenuating leaflet thrombosis was remaining, others was coming new up, others disappeared. So despite the fact that we did not change the antithrombotic therapy. So it seemed to be a hard to capture process which was not stationary but dynamic over time. Another important study then a year later, then I talk now about 3 years ago, was the Galileo trial. There was an actual randomization of patients who did not have indication for oral anticoagulation, so meaning patients in sinus rhythm, and they were randomized because that's also the patients where you see most of this leaflet thrombosis. The patients on oral anticoagulation because of atrial fibrillation, you see a very low incidence of this leaflet thickening, but it's these patients who only have the antiplatelet therapy where you see it more prevalent. So this was then also a perfect cohort in a way. This whole study was set up just to study atrial fibrillation and maybe post-procedural atrial fibrillation, new onset atrial fibrillation, whether these ischemic stroke rates could be reduced by giving them oral anticoagulation in the form of rivaroxaban, and then in the first 3 months rivaroxaban plus aspirin, and then rivaroxaban low dose as a continued treatment. Well, it actually also had a 4D CT, so a CT sub-cohort, which we were responsible for in Copenhagen, and it showed very interesting results. It showed indeed, it confirmed that those patients were they were on rivaroxaban treatment, that the halt, as you can see, the reduced leaflet motion or the leaflet thickening was significantly reduced with oral anticoagulation. But at the same time, we saw that, in fact, these patients, the mortality was higher in these patients getting rivaroxaban. So this was an alarming finding, and that's why this study was also prematurely terminated. So this also shows again that if you see this leaflet thickening or this leaflet thrombosis on one of these TAVI valves or in your patients, that you don't immediately have to go and attack this and treat this with oral anticoagulation, especially not in all elderly, frail patients, because it's finding a balance. I mean, you may get rid of this leaflet thickening, but on the other hand, you may expose this patient to a higher bleeding risk and even mortality risk. So it's always finding a balance between the perfect thromboembolic risk and the bleeding risk. So to me, at this stage, then I talk about 2 years ago, I would say, what is the real clinical impact? Well, impact on the immediate transvalvular gradient? No. In most of the cases, there was no immediate impact. Impact on thromboembolic event rate? Well, there was only the small signal of maybe a higher rate of transient TIAs, but that did not get confirmed in many other registries. And then impact on long-term mortality or impact on valve durability, that was still open questions. I want to show you something about these last two in some recent studies. So this is a study from a group from Minneapolis, from Soraya, and Vinny Bavat is also involved there. Well, this was generating some controversial conclusion to me. I think it's investigated quite a lot of hundreds of patients, and they tried to investigate the clinical impact of this halt, this leaflet thickening after TAVR. And their conclusion was that halt was found in 12% of patients, which matches kind of our data as well from and other registries, and it was independently associated with long-term mortality. Well, I do not fully agree on their conclusion. I mean, if you look to their methods of their study, they also show that when they had these CT scans very early to screen for this phenomenon, and actually when they found leaflet thickening, they put these patients on oral anticoagulation. That's what they write in the method. So you see patients who exhibited halt on 30-day CT were initiated on warfarin to a classical ENR 2 to 3 to 6 months. So what I think, and this was also what I formulated in some comments later, that I think the higher mortality they see, it's not due to the leaflet thickening they see, but it's just because we know that if you put these elderly, frail patients on oral anticoagulation, we know it from many studies, not only from Galileo, but it was confirmed in some other trials too, that you just see higher mortality. So I think this is not the right study to make real solid conclusions on that there is higher mortality in patients with HALT. On the other hand, there is a very nice, very recent study, as you can see, from 2022 from the German group, from Professor Neumann, from Freiburg, and they looked for what this long-term follow-up effect of HALT could be on gradients. And then I think they did a more strict approach. So they had these patients, 821 with CT post-TAVR, and then those with intermittent DOAC, they were pushed out. So those patients which had oral anticoagulation, they were pushed out of the study cohort. And then they have these pure patients with either HALT, where they did not change their antithrombotic therapy, or patients without leaflet thickening. And I think this is a more pure approach to study this. What you see is, first of all-cause mortality, where there was no difference in those patients with or without leaflet thickening up to 5 years. There was also no signal that there was a higher stroke or TIA rate. Even the opposite, I would say, as you can see in those with leaflet thickening, there was no signal whatsoever that there was a higher neurological event rate. But on the other hand, there was a signal that there was maybe more symptomatic hemodynamic valve deterioration, so that is leaflet thickening, and that may have an impact on valve durability and on structural valve deterioration on the longer term. And that does not look unlogical. So this would be my answer, the final answer, based on the question I got from the organizing committee. So what is the real clinical impact of reduced leaflet motion or leaflet thickening? Impact on the immediate transvalvular gradient? No. Impact on thromboembolic event rate? Well, there are some signals, but I don't think we have hard evidence to say that. Impact on long-term mortality? I do not think so. I think you even, if you would treat all these leaflet thickenings with oral anticoagulation, that you may induce indeed higher mortality, and I think it's better not to. An impact on valve durability? Probably yes, this will have an impact, I think. But of course, how to prevent or treat this subclinical leaflet thrombosis? I don't think we have to actively screen for it. It would be a mistake to get all our TAVI patients in the CT scan in series and follow up. I don't think we have to do this. But we should definitely think of it and consider the possibility of leaflet thickening in case of increase in the mean gradient of more than 10 millimeters mercury or more after TAVI. If you have your patient in follow-up and you see this, I think it's something here you have to think of. Also, if you see a very early TAVI degeneration, it's also something you have to think of, and you have to screen for this leaflet thickening, because it may be a very easy solution to put this patient on oral anticoagulation and treat it. Also, if this patient, a TAVI patient, has a neurological event, don't only think of atrial fibrillation, but also think on this leaflet thickening, and it's worth to screen for it in a patient who clearly has a neurological event. And then be more vigilant in patients on antiplatelet therapy, because those patients on oral anticoagulation, we know that the incidence rate of this leaflet thickening is much more lower than in those patients on antiplatelet therapy. Then a final slide on, because I sometimes get the question like, is there something we can do to prevent this? Well, I think that's a hard one to answer, but at least there are some data which shows that if you have, during your case, a very constrained frame, and then especially on valves, TAVI valves with intra-annular leaflet position, if this stent frame is very constrained, asymmetrical expansion, that these leaflets, which are like let's say on this picture, the non-coronary cusp, it's not 120 degrees nicely expanded as you would expect. Well, it's underexpanded, so these leaflets are more at risk for leaflet thrombosis. So that's one thing. As an operator during the case, if you see a massive constrained frame, maybe do a pulse dilatation. Also, your valve choice may have an impact on it. I think in all the cases we've seen, those TAVI valves with a supraannular leaflet position, they have less risk for this phenomenon. And then, of course, so that's why I wrote THV design, pulse dilatation, anticoagulant therapy. That's kind of therapies you can think of if you're struggling with this leaflet thickening in one of your patients. So thank you for your attention.
Thank you for your outstanding conferences. So it's been great to hear you once again. I have a few questions for you, but later on. So we want to hear now, once again, Dr. Makkar to talk about the very interesting topic, which is bicuspid aortic valve in TAVR.
Sure. Terrific. Let's see. So I'm going to talk now about bicuspid, TAVI and bicuspid aortic valves, but I'm going to talk primarily about bicuspid aortic stenosis and not, regurgitation. So these are my disclosures. I must start by saying that there are no randomized clinical trials in patients who have bicuspid aortic stenosis. We have no comparative data. In fact, I've made this argument multiple times that we should have randomized clinical trials because almost half the patients that undergo surgery for aortic stenosis have bicuspid aortic valves. And all the observational data that I'm going to show you is actually somewhat limited by the bias. We only may be treating more favorable patients. And surgery has produced good outcomes in patients with bicuspid aortic stenosis. So before we change it for TAVR, shouldn't we have some solid, rigorous trial data? And of course, the problem is that bicuspid aortic stenosis is anatomically very heterogeneous and is often accompanied by aortopathy, none of which was actually really studied in the IDE studies. So, but nonetheless, in absence of randomized trial data, let me make a case for TAVI in selected patients. So these are images from our imaging core lab, from our center. These are different bicuspid valves, as you can see. They may all be called bicuspid, but I think if you're planning to do a TAVR, it is very clear, right, that the implications to the operator are very different. The valve in the right lower corner is absolutely a very, very complex valve compared to the others. So I think this is very heterogeneous. The other thing to remember is that while we are told about this data, right, and this is data from Bill Roberts, from Baylor, where they looked at these valves when they did surgery, and almost 50% of the patients actually had bicuspid aortic valves. So that is the prevalence, right, in patients who are undergoing surgery. But then when you look at the data with TAVR, for example, in the US TVT registry, only 3 to 7% of the TAVRs were actually done for bicuspid aortic stenosis. So yes, it's because we were treating high risk and older patients, but even in younger or even in low risk patients, the incidence rose up to 10%. So I think there may be the selection bias in what we are actually treating. So I thought that I would start by showing you what is going on in our program, in our heart team. So here is these. Can you see the slides, or they're cutting off? I don't know what happened here. So, here's a patient who was young, in fact, and if you look at this patient's anatomy, there is heavy calcium. This patient today, we could have, the aorta is not beyond, it's the largest dimension is 4.3. We could have done TAVR. This was a little bit earlier, a few years ago. We presented the patient with different options, and the patient chose surgery, which is a good option. In this example, thank you. In this example, can you make it smaller, please, so that I can see the whole slide? Yeah. So in this example, the patient is 64 years old, and there's not a lot of calcium. But nonetheless, we were not keen, and we did not do a TAVR, because if you look at the ostium of the left main, it is 7.9 millimeters. So this is 64-year-old gentleman. There is a small risk we would occlude the coronary artery, and a small risk of the repeat TAVR in TAVR being not so good. So we send this patient for surgery. Now this is a physician who came to us from Arizona, a doctor, and he wanted TAVR, and I talked him out of it because if you look at his calcium, it is very eccentric. Just in one commissure, his annulus is very large, 669. He will get a very large surgical valve, and more importantly, his aorta is 4.5. I think during surgery, they can take care of his aorta. They can put a very large surgical aortic valve, and he can have a TAVR in SAVR, and maybe again another TAVR in SAVR. All right, so I think it is how we stack these things. Here's a patient who's 65 years old. This is not very good anatomy. Look at the LVOT calcium, but this 65, but he's got a bunch of other issues, Crohn's disease, factor V Leiden. He also has some intellectual disability. we actually did a TAVR in this patient because that was the right thing looking at the whole situation. We were careful. As you can see, there is LVOT calcium. All right, we were able to do this safely, and this patient went home. There's no PV leak. This patient went home the next day. And here is a patient, this was about 3 years ago, and I think we pushed the limits. Now, the annulus is okay in terms of sizing, but the left main is borderline, 9.9. But the sinuses are really large, all right? But she didn't want surgery, and we thought it's very reasonable to do this, and we will protect the left main, and we told the patient, you may end up with the left main stent. The sizing was between 26 and a 29. We chose a 26, put a little extra volume in there, all right? You can see that the TAVR device is actually far away from the left main, all right? So even though it is actually above the height, there is going to be no problem in accessing that left main. And in fact, this patient will be able to have a TAVR in TAVR, hopefully 10 years later, not sooner, all right? So I think we were able to do that. So and this is the echo result with mild paravalvular leak. So here is a patient with aortic regurgitation. I thought I'd remove this, but who had a repair done, and in this patient we used again a SAPIEN valve, and we were able to actually treat this. This is the echo data. Now, so this is 30-day echo in this patient. Now, here is a case example, and I wanted to show you. This is a case example which should not be done if a patient is a good surgical candidate. This patient was 75 years old, all right? And he was not a good surgical candidate, so we actually did it, right? And we got away. So we had a reasonably good outcome. And the reason why this is not a good case is because look at this. There is a calcified raphe, okay? There is calcium along that leaflet. And then there is parallel to that, there is another plate of calcium. All right, so there is this T calcium, another calcium. So you are going to have a risk of aortic root injury here. All right, but we got away and we got a reasonable result. But what I wanted to show you here is the follow-up. So this is what the CT scan was. You can see the amount of calcium here. You can also see as we balloon, okay, we have to do pre-ballooning, then we have to do post-ballooning. There was some trace or to mild paravalvular leak when we finished this case. All right. Now, this is a 30-day follow-up because we tend to do CTs in these patients for a number of different research projects, including leaflet thickening. And you can see, look at the valve. It is not circular. It's actually oval. All right. So I think that what impact will this have long-term on valve durability is not known. Now, at 30 days, once again, there was just a tiny bit of a leak. We can see at 9 p.m. Now, look at this at 2 years. All right. So at 2 years, the leakage seems to be more. So is this valve recoil? Is this the impact of calcium? Are we going to see this more often? I mean, the only way we will find out is if we do some of these cases, systematically follow them up, then we can say what impact this is going to have on long-term outcomes. So, now let's move to the data. All right, so I've shown some case examples to you. So the first piece of evidence that we generated data on was high-risk patients. This is published in 2019. And essentially what we showed was in bicuspid aortic stenosis patients, in the TVT registry, almost 2,700 patients, the outcomes were not bad. They were a little bit worse compared to tricuspid aortic stenosis, procedural outcomes. So conversion to open surgery was 0.9% instead of 0.4%. So yeah, statistically significant, but still less than 1%. Aortic root rupture, 0.3%, so not very common. All right, need for a second valve, 0.4%. If you look at all-cause mortality, it was actually similar, 2.6 and 2.5% at 30 days. Stroke rates were higher in these patients at 30 days. New pacemaker rate was not very different, though statistically a little bit higher. And aortic valve reintervention at 30 days was not high and not different. These are one-year outcomes between bicuspid and tricuspid, and you can actually see there was no difference in one-year mortality or one-year stroke, okay, which was actually higher at 30 days. Now, that was data with the balloon expandable sapien valve. There's also data with the self-expanding valve, and this is also from the TVT registry in high-risk patients. And this is average age was 73, the STS was 5.3. Once again, there was no difference between bicuspid and tricuspid, either in death rates or in stroke rates. The paravalvular leak rates were also not very different, though the mild paravalvular leak rate was a little bit higher. Now, so high-risk patients, we all understand doing TAVR. But the key question is, should we be doing this in patients who are low surgical risk, right? And that is the data that we were interested in. So that's the data that we extracted this time in this publication last year from the TVT registry. And there were almost 7,000 patients with bicuspid aortic valve that had undergone SAPIEN 3 valve, and 3,000 patients were actually low-risk patients. Okay, so we looked at different endpoints. These patients were 68 years old with an STS of 1.7. And what was the outcome? And if you look at the procedural outcomes, not bad at all. Conversion to open surgery, 0.4%. Aortic annulus rupture, 0.2%. Cardiopulmonary bypass, 0.5%. Aortic dissection, 0.1%. We were always concerned about coronary obstruction, which occurred only in 0.03%. So once again, these were selected patients, but what that shows you is when these patients were carefully selected, the outcomes were actually spectacular. And all-cause mortality at 30 days was 0.9%, less than 1%, which is very similar to what we actually see with surgery. And these are not cherry-picked patients. These are consecutive patients who were low surgical risk. Stroke rates were also not different. In hospital, mortality was only 0.6% in bicuspid compared to tricuspid. If you look at the long-term mortality, which is at 1 year, all right, I shouldn't call it long-term, at 1 year, the mortality was actually lower in bicuspid patients, 4.6% compared to 6.6%. So it's not because there is something magical about these patients. It's just because bicuspid AS occurs in younger patients, and even when you correct them by propensity matching, right, you are actually picking up somewhat healthier patients. All right. And these are some of the other secondary endpoints, which were also not bad in patients who actually underwent. So look at the rates of new pacemakers, slightly higher, but statistically not higher. If you look at aortic valve reintervention at 1 year, okay, it was 1.16%. So that's not bad. Right? So it is statistically higher than 0.4% in tricuspid, but these are very, very acceptable outcomes. The gradients were actually as low as tricuspid, and PV leak results were also not very different compared to tricuspid aortic stenosis. And when you look at the entire cohort of all 7,000 patients, irrespective of the risk, once again, you see that the mortality was, in fact, if anything, slightly lower, and there was no difference in stroke rates. So similar results have been seen in sponsored registries, right? These are cherry-picked patients. For example, only 2 out of 3 patients were selected in this particular registry, which was run by Edwards, and the outcomes were spectacular, 0%, 0%, all these things that you see for in hospital, and also 1-year outcomes are actually pretty good, right? 1-year mortality of 1.4% is very good. And here are some of the other things too, which are once again, very, very good in carefully selected patients. That's the key. PV leak rates are also not that bad. The same type of results were seen also with the Evolute. Okay, so these are not large registries, 150 or so patients. And once again, if you look at all-cause mortality with Evolute, it was 1.3%. I think the key question is what patients should we do and what patients should not be done. All right. So what we did was, my colleague Sanghan at Cedars-Sinai, when he was our fellow, we collected bicuspid AS TAVR patients from multiple sites, more than 1,000 patients, and we did CT core lab analysis on these patients. And this is the summary. The 30-day patients, the 30-day mortality in these patients who were 74 years old was 2%. The stroke rate was 2.4%. But and 90% of these patients were actually type 1 essentially, which is 1 RAFA, and 10% of the patients were type 0 or no RAFA. And what we did was we divided these patients into heavy calcium, no calcium, calcified RAFA, no calcified RAFA. And so essentially, then we looked at these patients and we showed was that your outcomes are worse when you're looking at This is, when you have a calcified raphe, you have worse outcomes. When you have no raphe and non-calcified raphe somewhere in the middle. Excess leaflet calcium has clearly 3 times more mortality than mild leaflet calcium. And in this multivariate analysis, calcified raphe type 1 was an independent predictor. Aortopathy was not in this particular analysis. So when you look at this, it was the combination. This is the central illustration from the manuscript that we published. Combination of calcified raphe and excess leaflet calcium had the worst outcomes. All right, so at 3 years, the mortality there was almost 4-fold compared to patients who had none of these features. And so what is the number of patients like that? In this particular series, almost 1 out of 4 patients had a combination of these adverse phenotype. So I think, let me go ahead and conclude what my take is from our experience and also from the published literature. I think what we can say is there are favorable outcomes with TAVR in carefully selected patients with SAPIEN and Evolute, in real-life TVT registry, and also in sponsored registries by the companies. I think what is most important is CT phenotyping. That's the term we devised in patient selection, but also in procedure planning. And I would say that while bicuspid TAVR is justifiable, irrespective of surgical risk, all right, high-risk anatomical features, concomitant aortopathy should make you think about surgery as a more reasonable option. I think what we need is randomized clinical trials, but we also need prospective registries with long-term outcomes, with imaging that is embedded in these patients. I think, and finally, I think I would say that I think we should continue to carefully do bicuspid aortic stenosis with TAVR, but I think what will result in a more meaningful contribution is essentially, collecting this data long term. But also as clinicians, we must take into account, what is the lifetime management? How do we start? Do we start with the TAVR or SAVR? And how do we optimize and how do we minimize the number of surgeries over a patient's lifetime to get the best results for our patients? So thank you.
Thank you. Starting our presentation. We have just 5 minutes left, so I don't want to miss time. And for Ole, Professor de Backer, just want to know, after having all the data we have with antiplatelets and the studies, the 3 studies comparing clopidogrel and aspirin and stuff, and all the Galileo and Atlantis and Envisage and popular TAVI trial, and now the ADAPT trial, and knowing that health is not related to brain lesions, important brain lesions, and in MRI, and not even changes in the decline of neurological assessment. A very practical question right now is how do you treat your patients after that?
Well, how we practically do it, I think the best evidence we have is indeed from the popular trials. I think those patients with no indication for oral anticoagulations, so typically, basically these patients in sinus rhythm, I think single antiplatelet therapy is good enough. There's no good arguments anymore to put them on double antiplatelet. At least that's not what we do anymore in Copenhagen. Only those who had, of course, a recent PCI or other reasons for the double antiplatelet therapy. And then the patients on atrial fibrillation, we put them on a single anticoagulant drug. Only if there's also another hard point to keep them on. For example, a previous ischemic stroke, neurologist wants to keep them absolutely on clopidogrel. They may end up still with clopidogrel plus oral anticoagulation, but otherwise we keep it as little as possible, I would say. And I think that's also the right way to do it. Of course, this whole story may change when we start to treat really young patients, like below 70 or 75, 70 years, because a lot of these data that I also showed with maybe a higher mortality with oral anticoagulation, etc., for those patients with, like in Galileo, I think this is maybe not valid for really young patients because they are more robust, less frail, they will not bleed, they will not die from it probably. So then we may have a higher concern of the durability of the valve. So maybe this whole reflection has to be changed when we treat these younger patients where we maybe need, I don't know, we have to investigate this, a transient, a short episode of oral anticoagulation to prevent the leaflet thickening. But okay, that has to be shown. There's a lot of research to be done still there in that field, I think. I don't know, Raj, if you have other comments.
I mean, I agree with you. Less is more, at least in the older patients. And I think we have to re-ask and restudy this when we go to younger patients. I think we need additional randomized clinical trials there. Long term, not just looking at, of course, clinical outcomes, but also valve durability.
Do you have any comments, Dr. Vera, Dr. Bonilla?
Well, I have a couple of questions. In these patients with small valves and infra-expanded prosthesis, would you actively look for the halt or just wait and see if the patient increases the gradients?
No, we don't have a strategy of actively screening to it, but as said, let's say you have a signal that the gradient goes slightly up, like you just before discharge, your mean gradient is 9, and you see your patients a year later, and that 9 mean gradient has become a 15. Well, I think, and you knew it was a bicuspid valve or something. I mean, you could think of it. There are maybe, I mean, it's hard to say if it's justified to really screen for it then, but if it gets, I mean, I don't know what you do, Raj, but then it depends a bit on how old this patient, if this is an 85-year-old patient, I would say, yeah, leave it as it is. But if it's a young patient, then I see a jump of mean gradient of 6 millimeters mercury just 1 year after the TAVI, knowing it's a bicuspid. I mean, I could screen for it, to be honest. Yeah.
I think only if patients are symptomatic and if they have really significant increase in gradients, you could make the argument to do it. And I think we now know that from the natural history studies, in fact, the ones that were done in Copenhagen, and the study that we did embedded in the partner trial, and the studies that were done embedded in the Medtronic trial, that half of the times, because we did CTs at 30 days and 1 year, and we did not alter, we did not treat, half of the times, patients who had halt, they had no halt at 1 year. All right? So and 20% of the patients who had no halt at 30 days actually had halt at 1 year. So it is actually a dynamic finding. And I give credit to the Copenhagen group for actually first showing that in the study that we collaborated on.
Well, thank you very much. Actually, we need to close our remarkable session. Really congratulations for your excellent lectures. We are really glad to have you here, but the time is over and we need to progress to the other session. Thank you very much for your assistance. Thank you for the panelists, and thank you for all of you.